Welcome to the deep dive. Today we're tackling a really important health issue, carotid artery disease.
Yeah.
This is when those arteries in your neck narrow
Yeah.
and it can, well, unfortunately lead to stroke. So figuring out how it's treated is pretty vital.
Absolutely. And when we talk treatments, there are really two main surgical paths doctors take. First, there's carotid endarterectomy, CEA. That's kind of the classic, the tried and true open surgery.
Right.
Then there's a newer kid on the block called Transcarotid Artery Revascularization, or TCAR. It's a less invasive technique.
Exactly, TCAR. So to really get a handle on how these two actually stack up, we're digging into some pretty significant research today.
Mm-hmm.
Our main source is Chapter 4 from 50 landmark papers every vascular and endovascular surgeon should know. And this chapter looks closely at a specific study called a multi-institutional analysis of transcarotid artery revascularization compared to carotid endarterectomy. It was in the Journal of Vascular Surgery back in 2019.
And our mission today really is to unpack what this study found. Putting TCRR head-to-head with CEA, what did the results show?
Mm-hmm.
And what could all this mean for patient care down the line?
Yeah.
We want to give you a clear picture of what each procedure brings to the table, the upsides, and the potential downsides too.
Okay, so TCR is the newer one. Why did doctors even start looking for a different way to do this? What was the push?
Well, it's interesting because TCR was developed with a very specific goal in mind, trying to minimize the risk of something called an embolic stroke during the procedure itself.
Ah,
That's when, little bits of plaque or debris break off and travel up to the brain. That's the big danger.
that's the main worry, yeah. So how does TCRR try and stop that? What's the mechanism?
The key idea with TCR is, first, they access the carotid artery directly in the neck.
Yeah.
But the really clever part is this technique called cerebral blood flow reversal.
Flow reversal, okay.
Yeah. During the procedure, they temporarily redirect the blood flow away from your brain. It goes through a filter system outside the body, gets cleaned essentially, and then returned. The thinking is that filter catches any stray bits before they can cause trouble.
That sounds pretty smart, technologically speaking. Now, the study also mentioned another minimal invasive option, TFCAS, Transfemoral Carotid Artery Stenting. How does TCR fit in compared to that one?
Right, TFCAS. So that involves going in through an artery in the leg, the groin, and threading catheters and stents all the way up through the aorta into the neck.
That sounds like a long journey.
It is. And the concern there has been potentially higher risk of stroke during the procedure. Navigating the big arch of the aorta, crossing the blockage itself, all without that guaranteed protection you get from the flow reversal in TCA. The filters used in TFCAS sometimes don't create a perfect seal either.
Okay, so TCR seems like it was designed to get around some of those potential issues with other less invasive methods, especially maybe for patients who weren't great candidates for the big open surgery, CEA.
Exactly right. There was definitely a need for a less invasive choice, especially for people who had other health problems that might make open surgery, a bit riskier for them.
All right, let's dive into this landmark study itself then. Kashyap and the team, 2019. What exactly were they trying to figure out?
Well, Kashyap and colleagues had a really clear objective. They wanted to compare how patients did, both in the first 30 days and then out to 1 year, after having either TCR or CEA.
Okay.
They wanted to see if TCR could deliver similar, maybe even better outcomes, particularly looking at things like stroke rates, death rates, and other complications.
And how did they actually set up that comparison? What did the study look like?
So they did a retrospective review. They looked back at patient records for people who had TCR at 4 different hospitals between 2013 and 2017.
Right.
And importantly, all those TCR procedures used that specific en route transcarotid neuroprotection system. That's the device with the flow reversal. Then they compared that TCR group to patients who had the traditional CEA surgery at the same hospitals around the same time.
Ah, same institutions. That makes sense for a comparison. But how did they make sure the patients were similar? Because you can imagine different types of patients getting different surgeries.
Yeah, that's a really critical point. They knew the groups might not be identical starting out, so they used a statistical method called propensity matching.
Propensity matching.
Yeah, think of it like creating pairs of patients, one TCAR and one CEA, who looked really similar on paper before their surgery. They matched them on things like age, gender, symptoms, diabetes, things like that.
Okay.
They ended up with 2 well-matched groups, 292 patients in each, TCRR and CEA. This just helps make sure you're comparing the surgeries, not just differences in the patients themselves.
That sounds vital, especially because the paper mentioned that before they did that matching, the TCR patients actually tended to have more health issues initially, like higher rates of diabetes, high cholesterol, heart problems, kidney issues.
Exactly. That initial difference just shows why that matching step was so crucial. It lets you see the effect of the procedure more clearly, kind of separate from the patient's baseline health.
Okay, so we get the background, the why behind TCR, and how the study was designed. Let's get to the bottom line. What did they actually find? How did the outcomes compare?
Well, this is where it gets really interesting. When they looked at the risk of stroke, both at 30 days and out to 1 year, the rates were quite similar between TCR and CEA.
Similar stroke rates.
Pretty much, yeah.
Uh,
Statistically speaking, this held true whether you looked at the original unmatched groups or those carefully matched groups.
okay.
So, for example, in the matched groups, the 30-day stroke rate was 1.0% for TCR, 0.3% for CEA, not a statistically significant difference. At 1 year, it was 2.8% versus 2.2%, again, statistically similar.
So essentially the same stroke risk in the first year for both procedures based on this data.
That's what this study suggested, yeah.
Yeah.
A really key finding for patients and doctors.
What about dying, the death rates?
Also quite similar. 30-day death rates were low overall and not statistically different. At 1 year, there was maybe a slight trend favoring TCR 1.8% versus 4.5% for CEA, but importantly, that difference didn't quite reach statistical significance in this study, so technically no difference found.
Okay. And they often look at a combined measure, right? Stroke, death, heart attack within the first month.
They did, and that composite outcome was also similar between the matched groups at 1 month, about 2.1% for TCR versus 1.7% for CEA. Again, no significant difference.
So looking at those major negative outcomes, stroke, death, heart attack, TCR, seem to be performing right alongside CEA.
Pretty much neck and neck based on this
I
data.
remember reading there was one area where TCR did seem to have a clear edge.
Yes, absolutely. This was a standout finding. The study showed a statistically significant decrease in cranial nerve injury with TCR.
Cranial nerve injury.
Yeah. Only 0.3% of the TCR patients had this complication, compared to 3.8% of the CEA patients.
Wow, okay, 0.3 versus 3.8%. That sounds like a substantial difference.
It really is.
Yeah.
And you have to think about what that means for the patient.
Right. For anyone listening, what kind of problems can cranial nerve injury cause after this type of neck surgery?
Well, these nerves control really important things like facial movement, swallowing, your voice.
Uh-huh.
So an injury during surgery can lead to, hoarseness, trouble swallowing, sometimes facial drooping. These can be temporary, but sometimes they persist and really affect someone's quality of life.
Definitely.
And the study authors even pointed out that in the CEA group, only about half of those nerve injuries had actually gotten better by the 6-month mark.
Oof. Okay, that really highlights a potential advantage for the TCR approach then. Were there any other differences between the groups noted in the study?
Yeah, one other thing they observed was related to medications. The TCR patients were more likely to be on antiplatelet drugs like clopidogrel and also on statins for cholesterol, both before and after their surgery, compared to the CEA group. The study gave specific numbers, and those differences were statistically significant.
Interesting. So different medication patterns alongside the different procedures. Okay, we've walked through the data. How did the researchers themselves wrap this all up? What was your take on what these findings meant?
Well, their main conclusion was that this early data suggested TCAR seemed to achieve broadly similar outcomes to CEA for those major events, even when used in patients who might have been considered higher surgical risk.
Right.
But, as we discussed, the really significant point for them was that lower rate of cranial nerve injury with TCR.
They sounded pretty positive about TCR's potential overall, didn't they?
They did, yeah. They mentioned their own good experience using it and said this big multi-center study was really driven by wanting to understand its results properly, collaborating across institutions. They kept coming back to that compelling feature, the mandatory flow reversal, as a key protective element against stroke during the procedure.
And did they comment on the practical side of actually doing the TCR surgery?
Yes, they did. They highlighted that TCR needs only a pretty small incision to expose the artery in the neck, and the surgeon is working over a relatively short distance.
Yeah.
They felt this made it technically less demanding, perhaps, and quicker for surgeons to get really good at. They even cited other data suggesting a learning curve of maybe just 10 to 15 cases to become proficient.
That's pretty fast for a new surgical technique.
It is. And crucially, that data also suggested that patients treated while surgeons were still in that early learning phase didn't seem to have worse outcomes. That's important reassurance.
Definitely. So what was their final word? What did they hope would happen next after publishing this?
They really expressed hope that these encouraging early findings would spur more research, specifically prospective studies looking forward, not backward, that would directly compare TCRR and CEA in an even wider range of patients, not just high-risk ones, but standard-risk patients too.
Got it. So let's try and synthesize this. This landmark 2019 paper gave us some important early evidence. It suggested TCR could be a comparable alternative to the established CEA surgery for carotid disease.
Right.
While those big outcomes like stroke and death looked similar, TCR showed this really notable benefit in reducing cranial nerve injuries, especially in a group that maybe had more health challenges to begin with.
That sums it up nicely. And it's so important to stress, as the authors did, that while these results were promising, they really saw it as a call for more research to confirm things and figure out exactly where TCR fits best.
It technically gives you something to think about. If the major risks like stroke are similar, but TCR is less invasive and seems to cause fewer of those potentially life-altering nerve injuries,
Right.
how might that shift treatment decisions going forward?
Exactly.
And for you listening, what other questions does this raise? What more would you want to know to really understand these choices if you or someone you knew were facing this? It's definitely an area to keep watching. Thanks for taking this deep dive with us today.